In this video, we are going to discuss about chronic suppurative otitis media, that is CSOM. CSOM is a chronic inflammation of the middle ear cleft which is characterized by persistent or recurrent ear discharge, that is also called as otorrhea, through a perforated tympanic membrane, and it lasts more than 12 weeks. So let's break out CSOM. Chronic means more than 12 weeks. Suppurative, that is discharge, and this discharge may be persistent or maybe because of recurrent ear discharge. And otitis media, as the name suggests, it is from the middle ear cleft. If anything from the middle ear should be draining out, the barrier is the tympanic membrane. If there is a perforation in the tympanic membrane, only through this perforation this discharge will come out. So for the recurrent ear discharge or for the otorrhea to come out, there will be a perforated tympanic membrane, and this will be lasting for more than 12 weeks. Only then it is called as chronic suppurative otitis media. This is the image showing discharging ear through a perforated tympanic membrane. And this perforation in the tympanic membrane can be of various types. Let's see them one by one. This is umbo of the malleus. Now this is the handle of the malleus forming a umbo. Right. So this becomes anterior part and this becomes posterior part. Again, this can be divided into antero-superior, antero-inferior, then posterior-superior, posterior-inferior. Here this is a central perforation or in the anterior perforation. Central perforation in the anterior part. This is central perforation which is larger than the anterior one. This is medium sized. This is almost subtotal perforation. This is total perforation with destruction of even the fibrous annulus. That is, there is no rim surrounding this. If there is a rim surrounding like this, then fibrous annulus is said to be intact. Here entire tympanic membrane has got perforated along with the destruction of fibrous annulus. Here it has been perforated in the attic region, so it is called as attic perforation. This is posterior superior marginal perforation. Margin is involved and posterior superior region is involved, so posterior superior marginal perforation. Out of among these types of perforation, central perforation and atticoantral perforation is most common, and based on that we have divided types of CSOM. So basically there is two types of CSOM. One is tubotympanic type, in which there is antero-inferior part of the middle ear is involved or central perforation is seen, and atticoantral type of CSOM, in which there will be posterior superior part of the middle ear involved and marginal or attic perforation is seen. So central perforation is seen in case of tubotympanic, and this is a safe type of CSOM, whereas in case of unsafe type, atticoantral perforation is involved. So since it is a safe type of CSOM, complications will be lesser in number. In atticoantral type of CSOM, complications will be more, and it is also associated with cholesteatoma formation and risk of complications. What is cholesteatoma actually? As we all know, external ear, then auditory canal. This will in turn end up with tympanic membrane, and after that whatever is there, that is middle ear. So this is a middle ear. As we all know, here the lining will be stratified squamous keratinized epithelium. And in the middle ear it will be secretory type or columnar type. So whatever the lining is there, that will be ending in the external auditory canal itself. In the middle ear it is a different type of epithelium. If this stratified squamous keratinized epithelium will start lining the middle ear also, then that is called as cholesteatoma formation. That is, the stratified squamous keratinized epithelium, which was not supposed to be found in middle ear, is found there now because of probably damage of the tympanic membrane. It will migrate and it will start depositing or start generating over there in the middle ear. So this is called as cholesteatoma formation. There are various theories and reasons explained for this. We'll not go into detail for that. Just remember, if there is atticoantral type of perforation, cholesteatoma formation risk is more. What is the etiology for chronic suppurative otitis media? Why does this happen actually? What are the predisposing factors? Recurrent acute otitis media. If the person is having recurrence of the acute otitis media again and again, then there is a high risk of him developing chronic suppurative otitis media. Similarly, inadequate treatment of acute otitis media will in turn lead to chronic otitis media. Poor socioeconomic status, again there will be increased risk of infection. This is nothing but AOM. Again, if it persists for more than 12 weeks, it will become CSOM. So increased poor economic status, they will have increased risk for infection, in turn having an increased risk for CSOM. Other than that, again eustachian tube dysfunction, this will lead to increased risk of AOM, again to CSOM. Nasopharyngeal infections like adenoids and all, again they'll pose an increased risk for infection leading to CSOM. Cleft palate and chronic rhinosinusitis in turn can lead to chronic suppurative otitis media also. What are the causative organisms that mainly cause CSOM? Mainly anaerobes like Pseudomonas, Proteus, Staphylococcus aureus, Klebsiella pneumoniae. All these will lead to development of CSOM. What is the pathology behind this? What exactly happens in CSOM? Imagine there is a persistent perforation of the tympanic membrane. So through this tympanic membrane, there will be infection of the middle ear mucosa. Basically, tympanic membrane is serving as a barrier and protecting the middle ear from external environment. So if there is a perforation, whatever the external pathogens are there, they can easily reach the middle ear through this perforation and in turn will lead to chronic infection. Other than this, there will be formation of granulation tissue or polyps in the middle ear. So this will in turn lead to formation of suppurative material like thing that will be discharging through the perforation of the tympanic membrane. And along with this, in case of unsafe type, that is atticoantral type, there will be formation of cholesteatoma also, which I had explained before, like keratinizing squamous epithelium, which is usually found in the external ear, is now found in middle ear. What are the clinical features? How does the patient present to us? Symptoms will be usually persistent and recurrent mucopurulent ear discharge. Kivi sore hote anta heltare. Okay, so persistent mucopurulent discharge will be there. Along with that, since there is accumulation of fluid in the middle ear, it will lead to conductive hearing loss. There will be no pain unless secondary infection or complication occurs. It will be painless, but mucopurulent discharge will be there. Hence, it is chronic in nature. Patient will neglect this because it is painless. Foul smelling discharge will be there, especially in case of atticoantral or unsafe type of CSOM. What are the signs? What we need to observe when the patient comes to us? These are the symptoms. This the patient himself will tell. I am having persistent ear discharge and I am not able to hear properly. There is no pain or anything, but smell is a bit weird. So all these things patient will himself tell to us. But what are the signs? What we need to look in the patient after he come to us? On otoscopy, we will see if there is a central perforation or a marginal perforation. If it is a central type of perforation, it is safe type. If it is marginal or atticoantral perforation, it is unsafe type. Also, we will have to look for oral polyp or granulation tissue in the middle ear through the tympanic membrane perforation. If it is there, it is a sure sign of CSOM. Other than that, if there is cholesteatoma formation or cholesteatoma debris are there or retraction pockets are there, this we need to look for on otoscopy. After this, what are the investigations we'll do? Just like I said before, otoscopy is the investigation of choice or first investigation we'll do to look for perforation and discharge. After this, if the patient complains, I am able to hear less, then for conductive hearing loss, we will have to do tuning fork tests. And in this case, there will be Rinne's negative and Weber will be lateralized. Other than this, we can go for pure tone audiometry and whatever the discharge is there, we can collect it and send for culture and sensitivity. And based on the organism growing there, we can select the appropriate antibiotic. Other than that, we can go for CT scan of temporal bone if there is that like the patient has presented at the later stages and we are looking at complications also. In that case, we will need CT scan of temporal bone. Other than that, X-ray of mastoids can be done to look for mastoid hair cell sclerosis. So these are the investigations usually we will do in case of CSOM. What is the treatment? Again, medical management, there is clear cut discharge from the ear. We will have to clean that, and that procedure is called as oral toilet, in which we will do dry like suctioning and dry mopping of the discharge. Other than that, topical antibiotics can be used because this is an infection and it is a suppurative infection. So topical antibiotics like ciprofloxacin, ofloxacin or steroid drops can be used. Systemic antibiotics can also be used if there is an acute exacerbation and systemic symptoms like fever and all, then we can use systemic antibiotics. Treatment of nasal or sinus infections, because we studied in the predisposing factors like chronic rhinosinusitis can also lead to CSOM, adenoids and nasopharyngeal infections can lead to chronic suppurative otitis media. So based on if that is a source of infection, then we will have to treat them with antihistamines and nasal decongestants. Along with that, we will have to avoid entry of water into the ear. If medical management is not possible, then we will have to go for surgical management. So what are the surgical procedures we'll do? For safe type or tubotympanic type of CSOM, we will go for myringoplasty, that is repair of the tympanic membrane perforation. If the tympanic membrane is perforated here in the central region, we will place a new graft like thing over this perforation, so that that is called as myringoplasty. Myringo refers to tympanic membrane and plasty refers to just like a mesh like thing, hernioplasty tara myringoplasty. So repair of the tympanic membrane. Other than that, tympanoplasty, again this includes ossicular reconstruction along with tympanic membrane repair. Okay, so that is the difference between myringoplasty and tympanoplasty. Other than that, we can also go for cortical mastoidectomy if mastoid is also involved. For unsafe type or atticoantral type of CSOM, we will go for modified radical mastoidectomy, that is, we will remove whatever the disease is visible to us, and this preserves hearing. Radical mastoidectomy, here for extensive disease, and here hearing cannot be preserved. Whatever disease or whatever the infected thing we are able to see, we will remove that. That is radical mastoidectomy. In modified radical mastoidectomy, we will try to preserve hearing and only remove the disease. What are the complications of CSOM? What happens if we don't treat CSOM at a time? This can be divided into extracranial complications outside the cranium and intracranial complications, that is within the cranium. So extracranial complications, if we know the relations of ear, it will be easier. So extracranially it is in contact with, it is in connection with mastoid, and then inner ear, that is labyrinth, and above roof is subperiosteum, that is periosteum, and then postoral, like behind the ear. So based on this, we can say mastoiditis can be a complication, extracranial complication of CSOM. Other than that, facial nerve palsy can happen. Then if the infection spreads to inner ear, it can lead to labyrinthitis. If it spreads to roof, it can lead to subperiosteal abscess. If it spreads behind the ear, then it can lead to a fistula called as post-oral fistula. So these are the extracranial complications. Intracranially, if it spreads to the brain, it can lead to inflammation of the brain or meninges called as meningitis. It can also lead to brain abscess. Or if it spreads to lateral sinus, it can cause lateral sinus thrombosis. Also, it can lead to obstruction of the CSF flow called as otitic hydrocephalus. And how do we prevent CSOM? Early treatment of acute otitis media. If we won't treat it within 12 weeks, only then it will become CSOM. If we treat it within that stage itself, like early treatment of AOM, it won't progress to CSOM. So that is the first treatment or first preventive measure. Other than that, other predisposing factors should be controlled, like upper respiratory tract infection, allergies. All this, if controlled, it won't lead to CSOM. Poor socioeconomic status, poor hygiene, that are the predisposing factors we studied. So controlling that by keeping good oral hygiene, we can maintain or we can prevent CSOM. Other than that, avoid swimming in the contaminated water so that infection won't spread even if there is perforation of the tympanic membrane. So in conclusion, CSOM is a preventable and a treatable cause of chronic ear discharge and hearing loss. Proper medical and surgical management is essential to prevent serious complications and to restore hearing. So this was all about CSOM.